All right, welcome everyone. This week we'll move on to mitral stenosis. Let's see. So this will all be, I hope, familiar with you. Systematic, as always, using a combination of echo assessments, so 2D, color Doppler, pulse wave, and continuous wave. Less pulse wave for mitral stenosis, I think. And ultimately, what we're going to be looking at is valve anatomy, valve hemodynamics, and what the hemodynamic consequences are, and combining that with the clinical assessment and putting that together with our echo mitral stenosis severity assessment to start making plans for patients. I guess from an ICU perspective, I wanted to put together ICU cases because we've had a couple recently that have come with sort of decompensation, and I'll maybe do that in a few weeks or something and show you some actual cases and how we managed and what happened. But I guess from our perspective, we see them either de novo when they don't know that they've got mitral stenosis and they present decompensated, congested, shocked, low cardiac output states and things like that. We've had a couple of pregnant patients in the past that have sort of presented de novo in pregnancy with the increased demands of pregnancy, increasing gradients and symptoms, etc. And then I guess sometimes we get them when they're waiting for intervention. So we had a patient probably about 2 months ago now that, Michael, I think you're involved with, that came with a pneumonia, but probably had exacerbation of the severe MS, and how we sort of manage that in reducing congestion, preventing tachycardias, trying to, he already had established atrial fibrillation, so that's pretty hard, but yeah, sort of altering their hemodynamics to not worsen gradients and things. Is a useful thing to go over. So I think we'll go over that another time, and I'll not cover it too much today for time constraints. So mitral valve stenosis, it's decreasing overall in its prevalence, but it is still a fairly common cause of native heart valve disease, with about a 10 to 12% prevalence. Usually it's isolated, but of course a significant amount will have concomitant mitral regurg as well, and maybe about a third of patients have combined MS and AS, and I guess very rarely we see tricuspid valve involvement as well. So as always, not just focusing on the mitral valve, but always looking for concomitant valvular disease as well is obviously important. Tends to affect females more than males, and females tend to present, they've had this childhood history of rheumatic fever. They don't always know they've had that, and then they tend to present with symptoms between ages of 20 and 40 usually. Rheumatic heart disease, rheumatic MS, is still the most common cause worldwide. It's decreased in industrialized countries, but it's still an important cause, and of course, especially in low income or low socioeconomic areas, it's quite prevalent. Degenerative disease, so mitral annular calcification, is an increasing cause of mitral stenosis, especially in higher income countries with people living longer, more renal disease, atherosclerosis, diabetes, hypertension, all the sort of risk factors for mitral annular calcification. On the whole, they tend not to have severe mitral stenosis like they would do with rheumatic, but of course there are a small percentage that are going to develop significant gradients. I read somewhere, and I don't think I've quoted it, that maybe around 0.2% of them or something will develop severe stenosis, and that depends on where the calcium deposits and how that then affects valve hemodynamics. Rarely we'll see radiation-induced MS congenital, like those parachute mitral valves, Cortria, Triatum, things like that. The more rare things, SLE and carcinoid, but majority are going to be rheumatic and degenerative. So I think that's where you should focus your attention. Of course, background, I'm not going to cover everything in this lecture. So background reading, the ASC guidelines, the BSC guidelines, and there's a whole wealth of lectures on, mitral stenosis that go into things in a lot more detail than what I will today. So please, don't take this as gospel and read around the topic, of course, as well. So the normal valve area for mitral valve is around 4 centimeters squared, and generally patients tend to get symptoms when this falls below 2 centimeters squared. Severe stenosis cutoff used to be 1 centimeter squared, but in the most recent update by Otto in American Heart Association guidelines from 2020, essentially a valve area of less than 1.5 can be consistent with severe mitral valve stenosis. So as we always say with any valve lesion, of course, we need to look at the whole heart. The main pathophysiology in MS, you've got this tight hole, preventing filling from your left atrium to your left ventricle, and you're going to have an increased gradient right between your left atrium and your left ventricle in diastole when the LV is meant to fill. And that gradient is super important. The higher that is, the more symptoms the patient's going to have, and the more severe the mitral valve stenosis is. Of course, when you have that increased gradient, you have less time for filling, and you might, develop symptoms because you've got reduced cardiac output, and then, eventually develop left atrial pressure increase, and that will give you symptoms of congestion and things as well. So there's left atrial dilatation. Of course, that atrium is susceptible to developing fibrillation and thrombus, and patients eventually will develop remodeling of their pulmonary circulation. They generally develop this post-capillary pulmonary hypertension with congestion, and then of course later down the track they're going to have RV dilatation and failure. So rheumatic heart disease, and as I said, it's the most common cause. Generally, it's streptococcal, group A streptococcal infection in childhood. The hallmark of rheumatic heart disease is commissural fusion. That's the key thing. But they also get leaflet tip thickening with fibrosis and calcium deposition as well at the leaflet tips predominantly. Their cords tend to be thick, and then they can shorten as well. And this obviously leads to that narrowed. We didn't talk in detail about the anatomy of the mitral valve, but of course we know it's sort of saddle shape, and then you have your chordae, your pap muscles, and it develops this sort of funnel shape in stenosis. So often the narrowest point is not necessarily where you think it is, and that I'll come in to talk about that when we talk about planimetry. And then you get these Ashkoff bodies. I'm not going to pretend I know anything more about that, but this is what they look like on histology, and what they look like at post-mortem there as well in that dissection. And you can see it's predominantly the leaflet tips that tend to be affected. This is in contrast to degenerative disease or mitral annular calcification leading to stenosis, where the patients tend to have this annular calcification, and the leaflet tips tend to be relatively spared. And as I say, it's typical in more elderly populations, and they often have a bit of aortic stenosis or regurg as well. And you can see that here we see this not infrequently, I suppose. This sort of mitral annular calcification tends to be quite prominent on the posterior mitral leaflet, but also can affect the aortic mitral curtain. I haven't referenced this slide, and I've had it in my talk for ages, and I need to find the reference. I'm sorry for whoever I've stolen it from without referencing them, but this I think it's quite nice just to highlight the differences between rheumatic and calcific. As I say, commissural fusion, they tend to be younger, and really the methods that we use for calculating that mitral valve area are going to be with planimetry and pressure half time. So pressure half time was sort of validated only in rheumatic mitral stenosis by Liv Hattle's group back in, I can't remember what decade, but 60s or 70s or something, maybe later. And it's not validated really for use in calcific. We still measure it, but there's it's not as accurate in calcific MS. And these patients, rheumatic patients, tend to benefit from percutaneous boom mitral valvuloplasty, which is definitely beyond the scope of this talk today. Whereas calcific MS, as I said, they tend to have sparing of the commissures and tend to be old. And generally, we still do measure pressure half time. Planimetries can be done, but maybe not as useful. So and again, using gradients and the continuity equation are some of the techniques that we might use as well. And we'll talk through some of them. And then, of course, for obvious reasons, they tend to be poor candidates for valvuloplasty because of all the calcium deposition at the annulus, which can cause cracking and complications sort of related to that. So you might be familiar with this. This is the Jace paper from 2009 that has all of the different valvular stenoses. So it has aortic stenosis in there as well. And this is the table, sort of how we classify severity of mitral stenosis. This is from 2009, so quite a while ago. Hey, and it used to be mild, moderate, severe, with this sort of less than 1 being severe for the valve area, mean gradient of more than 10, and pulmonary artery pressures are more than 50. I guess in the more recent updates, in the 2020 guidelines, you can see how they now sort of classify as stage A to D, and then just drawing your attention to severe MS, whether it's asymptomatic or symptomatic. The valve anatomy, planimeter valve area of less than 1.5, is in keeping with severe. Here, the pressure half times of more than 150 milliseconds is in keeping with severe. So these are important numbers to bear in mind. And they've taken emphasis off the gradient. You'll see that the gradient doesn't appear here. And that's because the gradient is so dependent on flow hemodynamics, which we'll talk through. And so it's highly fluctuant, depending on heart rates, cardiac outputs, all of that. So it's still, of course, important to measure it and get an idea, and trend as well, but not hanging your hat just solely on the mean gradient. And they say that in these guidelines, they say that, you don't have to have it only above 10. A gradient of 5 to 10 could be consistent with severe. And of course, if you've got someone with a low cardiac output, they might not be able to mount that high gradient as well. And of course, then the hemodynamic consequences that we look for. So if they've got big left atria, and they've developed pulmonary vascular dysfunction, right, with pulmonary hypertension, and they generally use PASP of more than 50 as a cutoff. And of course, you need to correlate all of this with how the patient is going clinically. And if you're seeing on echocardiography a really severe looking valve, but your patient is completely asymptomatic, then they recommend exercising them to sort of minimize that discordance that you're seeing between clinical symptoms and echo grading. So the main methods that we use for quantifying the mitral valve area are going to be direct planimetry, pressure half time, and then very rarely, because it's quite hard to do and there's lots of pitfalls and error measurements, the continuity equation and PISA. So we'll talk through some of that. So this is I realize I've been talking for a while now. Michael or Umi, you're up on my screen. So do you want to, might you want to comment on this loop? Can you see it all right?
Okay, so it's a parasternal long axis view, and there's an abnormality of the mitral valve. It looks like there's thickening of the leaflet tips, and the LA is very large. I can't see the posterior mitral valve leaflet very well, but it also looks pretty thickened. And there's a bit of doming of the leaflet as well in systole. And it looks like there's a lot of fissures on the screen, a lot of fish mouth action. So I think it's probably consistent with mitral stenosis. It would be consistent with someone who has probably mitral stenosis if we see it in other views.
Yeah, and it's got all the hallmark features of rheumatic mitral stenosis, hasn't it? It's lovely. So some of the key things to look for is this keyword that you mentioned, that doming of the thickened anterior mitral leaflet towards the left ventricular septum. So that hockey stick appearance is just classic of rheumatic mitral stenosis. And as it's opening, it sort of collects the blood, so it's like a sail in the wind, if you like. That's why it sort of hockey sticks towards the left ventricular septum as well. So that's classic, what you would see on a parasternal long axis. And also we tend to see this, it also appears thickened at the tips, which you can see, and then the posterior leaflet does tend to be thickened and restricted, and you can't really see it that well, but probably some of the chordae are quite thickened as well. Yeah, this is absolutely just to show that fish mouth appearance, that commissural fusion in rheumatic mitral stenosis, which you can see here and here. And again, I've been very naughty not referencing those. So I guess the key thing that I'm not going to go into, but I just do want to emphasize, is that it's not just about the leaflets. We need to look at the subvalvular apparatus as well, looking at the cords, how much the thickening, the calcification, etc., extends down into the cords, and even extending in more severe area, down into the pap muscles. And there is a few different scoring systems, and the Wilkins one is one that we probably are familiar with. I absolutely always need to look it up. You will need to know some of this for exams, for the American exam. You'll need to know it exists for the DDU, but not be able, no, you won't need to know how to do it. And yeah, it's important to just be aware that that's out there, and please do a bit more reading on that in its role in patient selection for valvulotomy. So yeah, important to look at everything, and this is just showing that thickened anterior mitral leaflet that we would see as well. So another example. Do I have any other volunteers just to practice? Rishi, perhaps you might want to just talk through this loop. Don't feel like you have to. Yeah.
Parasternal long axis view, which shows a zoom view of the mitral valve, showing again thickening at the tips with a hugely which is dilated left atrium. LV contractility appears normal. Can't see much of the aortic valve. RV outflow tract is partially cut off. Yeah, the anterior doming of the anterior mitral valve is also apparent. So it will be more consistent towards mitral stenosis with anterior doming of the anterior mitral valve, reduced opening of the excursion of the anterior and posterior mitral valve, thickening at the tips, and the dilated left atrium.
That's really nice, Rishi. Yeah, I'll just show that doming again for everyone. So that sort of hockey stick doming there. Put my laser on it. Yeah, absolutely classic of rheumatic, isn't it? Very nice. And this patient, and the stem in the DD would be something like, a history of rheumatic fever or something. Bonus points for this one.
Yeah, so this is a M-mode through the tip of the mitral valve, showing the excursion of the anterior and posterior mitral leaflets. Again, showing a reduced opening between the anterior and posterior mitral leaflets, and anterior motion of the posterior mitral leaflet, reduced EF slope. And there's also rhythm is also showing in AF, is more consistent with the dilated left atrium, probably as a consequence of the mitral stenosis.
Lovely, lovely, Rishi. Yeah, exactly as Rishi was just saying there. Generally in the M mode, it's not, obviously it doesn't need to be part of the general sort of how you grade severity, but it's nice in exams, and it's nice to show as well in sort of talks and things. So you generally get these thickened immobile leaflets. You get this is normal, of course, nice and pliable, this steep EF slope. In mitral stenosis, you get this reduced EF slope, and obviously if they're in atrial fibrillation, you don't see this A wave as well. And then the leaflets themselves tend to be thickened and immobile, so you don't see that lovely normal pattern. Nice. And that's what the normal should look like. This would be classic of a sort of fish mouth appearance. It's a short axis at the level of the mitral valve, and that's the same patient, Rishi, the one that you had just commented on the parasternal long axis on. And you can appreciate a bit of thickening at the tips there. You can't really appreciate the commissural fusion so much here, and maybe the gain is not quite optimized, is it? But you get the idea that you've got that sort of fish mouth opening. Planimetry. So of course we tend to avoid planimetry and things like aortic stenosis, and certainly when you've got lots of calcium there with that blooming artifact, it can be tricky. But we do tend to try to do our best with planimetry, with 2D on transthoracic echo, and if we're using the more advanced probes, you know, the X-plane probes with TTE, you'll often see the sonographers trying to do 3D planimetry as well with TTE. And of course we do that when we do transesophageal echo as well, because it's pretty good. So especially 3D planimetry is excellent, especially with transesophageal echo as well. And the reason that I might just come on to that. The reason that 3D is better than 2D is because of that funnel shape that I was talking about. So you see, if we take this planimetered value here of 2 centimeters squared, we don't know whether we're taking that at the level of the annulus, or, you know, we're slightly off axis perhaps, or we're not taking it at the level, like the funnel at the narrowest point. So what, of course, what we can do with 3D is measure it, cut through exactly where we want to cut through, and then sort of move up and down to find that narrowest point in the funnel. This is the 3D picture here, and then we would planimeter, you know, that part there, and it's pretty good, and recommended. So just to show a few more loops of this patient, just to give you a feel for what rheumatic would normally look like. So preserve left ventricular systolic function, hey, with thickening of the tips in particular, and severely reduced excursion in 2D. This is showing the ginormous left atrium. And of course, you'd be highly suspicious for any, and raised left atrial pressure. Look at that bowing across there. This patient's going to have raised left atrial pressure. And also important to be looking, obviously we can't see that on TTE, but when we do TOE or the imaging, looking for LA thrombus. LA thrombus doesn't always have to be in the appendage. You need to really fan through that left atrium and make sure you're looking for thrombus in the whole of the left atrium as best you can. Easy to miss. All right, so then moving on from 2D to colored Doppler. Classically, we would see this flame-shaped jet, is what we talk about. And then you often see this PISA on the inflow as well. So I'll just show that. You can see that the scale is appropriate. It's got that awful variance on, which I'm not a massive fan of. I tend to turn that off. But anyway, it shows turbulence, doesn't it, in the inflow. And can you just see there, if I pause it, here you've got that PISA, which is quite flat here. There's a pointer. This sort of flattened PISA. It's not that beautiful hemispheric that you might be able to do a PISA on, really. I don't know, but you can see that flow convergence as it's coming in as well, and that flame shape. So just training your eye to see that highly turbulent flow going in as we would expect in diastole. And another example here. Umi, might you want to comment on what you can see with this color Doppler and how you might optimize it?
The scale is appropriate for the color Doppler. In terms of just the movement of the leaflet, it's quite restricted. The exertion is very limited. And then we can see the variance in the color. And in terms of just the severity on the eyeballing, it's going to be severe because it's all the way through the end of the chamber, of the atrial chamber. And optimization, I think probably the angle is like good, reasonably good.
Yes, it's really hard, obviously, to call severity. All you can say is that there's turbulence through that LV inflow, which is consistent with mitral stenosis, but you can't comment at all on severity. You know, just using the color, you can just say that there's turbulent flow through that inflow. Very nice. And again, what we're seeing here is a jet of mitral regurgitation there as well. You see that? It looks pretty mild, but of course we'd need to see that in in more views as well. And it's not uncommon for them to have concomitant mitral regurg, which could just make things a bit more complex in terms of severity assessment. So it's probably, you know, mild to moderate MR. We'd need to look at that more together with the MS, isn't it? But nice, the scale's optimized. Probably the color box for what you want to see is pretty good actually for mitral stenosis. You want to see that turbulent color inflow. You don't want to miss any significant regurg. You could maybe argue to make it a little bit smaller, but not too bad. So can you all see that sort of PISA on the inflow with that lots of turbulence, as well as the mitral regurg jet as well? And then this is showing, I think this is a different patient, but again, just showing that turbulent inflow. I'm going to slow it all down for you. And I'd recommend doing this in your clinical practice as well. So diastole is just starting here. And we've got turbulent inflow coming in. What can we also see a little trace of AR there as well? You see that in diastole? So we've got turbulent inflow, some AR in diastole, and then in systole, which is just starting there, we've got that big jet of mitral regurgitation. Again, hard to quantify. It looks like it's probably moderate, but difficult to say just on this one view. And that really dilated left atrium as well. So always worth just slowing down, especially if you can't quite figure out if there's MR and MS and all of that. And just sort of scroll through that. So then continuous wave Doppler, right? And this is where we start getting into quantitative territory and trying to get some values. So the first thing we often do is measure the mean gradient, and we're going to use continuous wave Doppler. We're going to drop that through, as we can see here, through the mitral inflow. Generally having this, your sweep speed at 100 is probably better. I think this was maybe left at 50 to try and get 5 on the screen or something to try and average out the gradient, because this patient's in atrial fibrillation. But generally, the usual principles, right? So bringing this baseline down would be a way to optimize it. So bringing the baseline down, because you're interested in what's going through, you know, above the baseline here, aren't you? You see how you've got this black sort of ghosting here. So just reducing the low pass filter as well, just trying to minimize this sort of loss here, just to improve your accuracy. Again, increasing to about 100 to get 2 to 3 on the screen. And then not really tracing out this fuzzy bit here, but trying to get the peak velocity as you're sort of tracing around as well. So this is not perfect by any stretch, but it gives you an idea. And the mean gradient for this patient is around 7.5 if we sort of average those out. Problems with gradients. We got any thoughts about things that might interfere with those gradients that we're measuring?
The cardiac output.
Absolutely, yeah, cardiac output. So higher cardiac output, higher gradients; lower cardiac output, low gradients. Definitely, yeah. Anything else?
There is the left atrium is quite stiff and quite distended, stiff, non-compliant.
Yeah, that tends to cause us more trouble with pressure half time, Rishi.
Okay.
Yeah, because I mean, it's that gradient that we're measuring, aren't we, between the LA and the LV? It's that gradient that we want to know, like, is that big? Because that's going to give us an idea. But it's affected by anything that alters the flow state across the valve. So mitral regurgitation is going to increase the gradient. You know, so this patient here has probably severe, I know from this case, they have probably severe mitral regurgitation and not much in the way of stenosis, but the gradient's almost coming, the mean gradient's almost coming to 5. And probably a lot of that is coming from, you know, the increased flow from the mitral regurg. And just an eyeball way to sort of look at that is if you're seeing this really, you know, really sort of low pressure half time, like it's, you know, it's the pressure gradients are reducing quite quickly, isn't it? So if you're seeing that happen, then as opposed to being like this, if this was straight line, then it's taking ages for that pressure to equalize and stuff. So that can give you an idea that you're dealing with a not a significantly stenosed valve, but probably the gradients are up, you know, because of the mitral regurgitation. And then the other key thing is heart rate. So those are sort of the main things I would say that impact mean gradient, and we should be reporting heart rate along with any mean gradient, so that we can contextualize with different studies as we're monitoring the patients. So the pressure half time is what you were talking about there, Rishi, in terms of the compliance of the LV and the LA will affect this, absolutely. So of course, if we have our LV pressure time tracing in normal and our LA pressure time, you know, there's usually in diastole only transient and very small gradients, isn't there? Because we've got a lovely sort of 4 centimeter opening. When we have mitral stenosis, that's obviously coming down to about 1 centimeter, and then we get this in diastole, we get this huge gradient between our LV and LA. And the time taken for that gradient to fall by half is the pressure half time. Yes, it's the time taken. And when this was validated, you know, for mitral valve area, they found this empirical sort of factor of 220. So dividing your pressure half time by 220 will give you an estimate of mitral valve area. And it's, you know, it's mainly only validated in rheumatic mitral stenosis. There might be more data now for calcific, I'm not sure, but the original studies certainly were done on rheumatic mitral stenosis. There is another way that we can calculate pressure half time, and that's using the deceleration time, and you'll see that come up on. It's not on any of these. It might be on some more of them, but you'll see the decel time as well when you're measuring that, and you can times that decel time by 0.29, and that will give you a pressure half time, which you can then plug into this empirical equation and get an estimate of what the mitral valve area is. We're not talking about prosthetic valves today, but this is not valid in prosthetic valves. We shouldn't use pressure half time to calculate mitral valve area in prosthetic heart valves, and we should be using the continuity equation whenever we can. So this is kind of how we would measure it. Again, this is not perfect, right? You've got all this beat to beat variation, but you essentially just draw it. There'll be there's an option for pressure half time, and you're trying to trace this out as best you can, and you can see from this patient, their pressure half time varies, right, between 157 and 210. So you know that number of 150 milliseconds that they talk about in the guidelines is sort of going above that, isn't it? So it's consistent with severe mitral stenosis based on the pressure half time. And the mitral valve area that it's giving us is varying between 1 and 1.4. So again, in that severe territory for mitral valve area as well. And they've just the machines just worked that out by doing 220 over 210 to give you the mitral valve area by pressure half time. Any questions about that so far? So we should be doing this on all of the patients. We should absolutely measure pressure half time in prosthetic valves, but don't use it for calculating mitral valve area in prosthetic valves. Absolutely, we can use it for rheumatic mitral stenosis and stuff. Some of the pitfalls which Rishi was mentioning is, of course, you know, imagine an egg timer, right? Or these sand egg timer things. The only thing that's determining how that sand flows from the left atrium to the left ventricle, if you like, is the size of this orifice. But obviously the heart is not like that. So the rate at which this blood is flowing through, and which those pressures then equalize again, is going to be dependent on how stiff the left atrium is, whether there's a shunt in the left atrium up here and blood is all going across to the right side, how stiff the left ventricle is, and whether there's things like aortic regurg coming back through, right, and increasing that left ventricular end diastolic pressure with AR. So all of these things can interfere with pressure half time, and therefore interfere with what calculation you get for mitral valve area. So it's not that helpful if you've got conditions that impact LV compliance, LA compliance, and this is going to be like elderly patients with diastolic dysfunction, severe AR. As I said already, it's less accurate in the calcific mitral stenosis group. I'm not sure of the latest literature on all of that, but that's generally sort of how it's taught. And we shouldn't be using this pressure half time after balloon valvuloplasty because it's inaccurate. That's because you've got lots of quick changes to your left atrial compliance and things after those procedures. So to be aware of some of those pitfalls, this could absolutely be a question in the written for the DDU, and just being able to describe that and say when you would, be cautious with pressure half time. And this is, again, very bad for not referencing these, I apologize, but the impact, so this is quite nice, I think, to show this. So Lutten-Backer syndrome, again, this is an ASC work. If you've got a patient with an ASD and mitral stenosis together, that's called Lutten-Backer syndrome, pub quiz stuff, unless you're a cardiologist, of course, and then you need to know all of this. But this then what that means is your blood is all shunting across to the left side, and so your left atrial pressure is reduced. So your actual your gradient using the pressure half time method will then underestimate your true severity, because it'll underestimate the mitral, it will overestimate the mitral valve area, because it'll give you a smaller number for your pressure half time, and therefore smaller denominator, and give you a higher mitral valve area. So you're going to underestimate severity of mitral stenosis. Kind of similar principle, but the opposite really. So high left ventricular pressures, that's going to impact the gradient, make the gradient less, and then again shorten the pressure half time and increase the mitral valve area calculation, so underestimating the severity of mitral stenosis. So these are the pitfalls you need to be aware of with that. The other things that I find really tricky for pressure half time calculation is if you've got this convex shape, and this is a patient with severe rip-roaring stenosis, actually through a prosthetic valve here, mean gradient of 38, as you can see. And this is what you tend to see when it's terribly, like when it's very, very severe, that is usually this sort of flat profile or this sort of convex shape actually. And you can imagine you cannot trace pressure half time out on that. Beat-to-beat variability can cause some trouble, and I don't know, probably averaging is the way to go, which is that case I just showed you. Sometimes you get this sort of concave looking trace, and it's, you just sort of have to do your best with trying to trace that out as best you can. I'd probably start from here and sort of work my way up there instead. And then if you've got this ski slope appearance, which is not that uncommon, especially if they're still in sinus rhythm, then don't measure your pressure half time from this initial peak. Measure it from this middle one here, just where this yellow dashed line is. So yeah, start from here and sort of measure the slope there, is what's recommended. And this is a common question in the exams. There's a line drawn from there to there. Maybe a line drawn, I don't know, somewhere like here to here, and then this one, which is the correct one, the last which one maybe you'll see is like the correct one, would be common. So we've kind of gone through planimetry, gradient, pressure half time. Any questions about those? I think most of us now will be familiar with measuring, you know, TRV max, adding that onto right atrial pressure estimate or CVP if you've got that, and using the Bernoulli principle to estimate pulmonary artery systolic pressure. And if it's more than 50, it's associated with severe MS. So this particular patient here has a TRV max of 2.61, so 4V squared gives us 27. And then the right atrial pressure on this patient was 15, so not quite reaching 50. It's important to be trending that. And again, you know, if the patient's got more symptoms and they've got echo signs of right heart dysfunction, right heart failure, but they haven't got symptoms and stuff, you might find that when you exercise them, this will shoot up, as well as the gradient. Okay. Continuity equation then. So another technique that we can use for mitral valve area. And this is, as I said, this is recommended in mitral valve prostheses, where we shouldn't use pressure half time to calculate mitral valve area. And it's the continuity equation that we're familiar with now. So mitral valve area equals the cross-sectional area of your LVOT times the VTI of your LVOT over your mitral valve VTI. Okay, and it provides this estimation of your effective orifice area, as we know, which is often smaller than the anatomical orifice area. And that's the same principle in aortic stenosis as well. So I'm going to give you some numbers. Have you all got like a calculator or a piece of paper? I think the numbers are easy. No, I definitely need a calculator. But so what's the mitral valve area of the mitral stenosis in the following patient? Can I just say before you do it, ignore all of these values here, just the LVOT diameter I've put down here, it's 2. And the VTI is averaged at 16, and the mitral valve VTI is 63. And the mean gradient, 17.5. Anyone?
Is it 0.5?
No.
Good.
0.9.
What did you get?
0.9.
Oh, it's almost 0.9, 0.8. Maybe I've given you the wrong numbers. Anyway, it ends up being, so cross-sectional area, pi r squared, times 16, the LVOT VTI. Did I give you the right one? Yeah. Double check my maths. That comes to 50 over 63. That gives us 0.8.
Yeah.
Yeah, and it actually has it there as well for anyone that's wants to cheat. But this would actually be absolutely fair game in. I tend not to ask this in the DDU, hey, but it'd be fair game in the American exam for sure. And they often give you like other things that you don't need for the calculation, like mean gradient, pressure half time, decel time, just to try and confuse you a little bit. So you just need to know what you need to have. When could you not use this so much, do you think? When shouldn't you use it in particular? So AR and MR, right? So if you've got bad AR, bad MR, you can't hang your hat on this. It's just got to muck up all your numbers, make it inaccurate. Very rarely, if you have perfect conditions, and I must admit, well, I say I haven't seen anyone use it. This is a patient from an ICU that I worked in, but we rarely use PISA to calculate mitral stenosis severity. We tend to use planimetry, gradients, pressure half time. You know, those are the things that you're going to use on and 2D subjective as well, and the LA size and symptoms and stuff like that, rather than be using PISA. But it's there and you can use it. It has lots of caveats, which are I guess things that we've spoken about before, and a lot of it in MS is the need for angle correction because of the shape of your annulus. But PISA is essentially like your continuity principle, right? In that what goes in must come out, and as you're coming towards a narrowing, you get these hemispheric shells form, these isovelocity shells forming, and you can see that the baseline, rather than being reduced in the direction of MR, which is I guess where we're more commonly using it, aren't we, is reduced in the direction. So you bring down the baseline in the direction of the stenotic jet. So this patient's has been brought down to 28, so their velocity is 28, and these are the two equations that you need to know for PISA, right? So it's really quite straightforward kind of, but there's lots of caveats with it. So cross-sectional area of a hemisphere, which is 2 pi r squared, right? So that's the radius of your PISA radius, 2 pi r squared, which is this one here. So the radius is measured here at 1. You can see that there, mitral valve radius of 1, aliasing velocity 28.9. Right, so you plug that into this initial equation, which is cross-sectional area, aliasing velocity. So 2 pi r squared, because it's a hemisphere, times 28.9 gives you the flow, an estimate of flow, so 181 mils. Then you take this flow in the second part, and you divide that by the Vmax through your mitral valve, so the maximal velocity, so flow over velocity equals area, and that makes sense, right? So peak velocity here is 192 in centimeters squared. You need to have your in centimeters actually for your equation to, for your numbers to come out properly. There's calculators online that you can use as well to plug all this in, and also the machine will work it out for you. And then that gives you a mitral valve area of 0.94, and then you correct it for the angle, which again you can measure, which was 160 in this patient. So it ended up coming out mitral valve area by PISA of 0.84. You can see that this is not a bad one to do it on, actually. But this one would be quite hard to do it on. You've got this non-hemispheric, quite flat profile. But when it's flat, you don't always need to angle correct so much. But yeah, many caveats with this, and it tends not to be used in sort of day-to-day practice for MS in our lab anyway. Some places might use it more, of course. Stand to be corrected on that. So you need to choose the best method for this situation. And I think in the ICU, if you've got someone where you think they've got severe MS, especially, generally especially if they're intubated and things, you're going to be doing your TTE, and then probably moving to tone, doing 3D planimetry, checking a gradient, checking the pressure half time and mitral valve area by pressure half time. I mean, if you can do a continuity equation, but if they've got MR, AR, things like that, you're not going to be able to, or difficult windows, you're not going to be able to do that. But those are the things that I'd be using on a day-to-day basis. Know the caveats with them, so just please have a read about this in more detail. So planimetry, know about the caveats with that, but generally it's we should be doing it. It's pretty good, especially 3D. Pressure half time, again, not after valvuloplasty, not in prosthetic valves to calculate mitral valve area. You should still measure the pressure half time, of course, because if that's prolonged, that's more in keeping with a stenosis. In both native and prosthetic valves, of course, and the things that impact compliance of your LA and LV, so severe AR. I haven't gone into the complexities of that. You can have different impacts on your pressure half time from severe AR, depending on whether it increases your left ventricular end diastolic pressure or not. So if it doesn't, then you're going to overestimate severity, and if it does increase LV EDP, you're going to underestimate severity of stenosis. So it can almost have this sort of double-edged effect, AR, which makes it a bit complicated. But essentially, it kind of makes sense when you think about that, I guess, that egg timer and how long the time taken for that pressure gradient to come back again. If it's going to take ages for your LA and your LV to come back and equalize their pressures, anything that's going to do that's going to mess up the pressure half-time, therefore mess up your MVA. As I said, the continuity equation we can't use with AR, MR. It says severe. I'd be cautious using it with anything above moderate, really. And then PISA, again, takes a bit of time, lots of area for error, and I wouldn't advise, especially starting off in echo, using it. You'd need someone a good sonographer and sort of mentor to be teaching you how to do all of that properly, I think. All right, guys, I think we've got like 5 minutes left. So do you want to have any volunteers to just go through, practice again that cadence, that talking for your Viva? Just sort of, Michael, do you want to take this one?
Yep, sure.
You'd get more of a stem. You get more of a stem in your Viva, but there you go.
Okay, so the top left is a parasternal long axis view with a color wave Doppler that shows there's abnormalities are obviously severely dilated left atrium and an abnormal mitral valve with thickened mitral valve leaflet tips, doming of the anterior mitral valve leaflet, and what looks like both turbulent inflow, mitral inflow, and there's significant mitral regurg, which looks like at least moderate on this view, and I'd like to see in other windows. The LV otherwise, I'd like to measure it, but it may appear a little bit dilated, but the LV systolic function looks normal, and the aortic valve in this view looks normal structurally. In the bottom right, there's a M mode through the mitral valve leaflet tips that shows minimal movement of the posterior mitral valve leaflet, and there is reduced excursion of the anterior mitral valve leaflet, consistent with restriction, and I think this is consistent with rheumatic mitral stenosis. So there's a apical 4-chamber and a apical 2-chamber view, the 2-chamber with a color wave, so color Doppler. The apical 4-chamber shows that obviously enlarged left atrium with raised left atrial pressure and the septum bowing to the right, and obviously abnormal mitral valve with severely thickened leaflet tips. No obvious mitral annular calcification again, and what looks like normal LV systolic function, and a tiny compressed right ventricle and right atrium. And then the color Doppler shows turbulent mitral inflow with flow convergence and a PISA, and there is again significant mitral regurg that actually looks pretty severe in this view. It's eccentric, it's anteriorly directed, and I'd be worried about severe mitral regurg in this patient as well.
Oh,
so
ignore this part of the screen, Michael. Don't look at the writing. Sorry.
I'm covering it.
Yeah.
Umi can see. So this is a continuous wave Doppler through the mitral valve inflow that shows a mean pressure gradient of 7. So I guess you need to take it into account with multiple other measures. Classically, that would fall into the moderate category, but it could still be consistent with severe if you had values of like the D cell time, symptoms, and things like that. Peak velocity is 1.9, which is also could be consistent with severe. And you can see it's not traced out properly, but obviously you can see some of that mitral regurg below the baseline too.
Nice, Michael. Oh, that was lovely. I thought you did really well there. You picked up on all the key points. It was like really, focused on the key areas. I know it's easier because it's a kind of mitral stenosis. If you were seeing it de novo, but that was lovely. That was so nice. I haven't got much to add to that. I thought it was lovely. Really good. I guess just that wall hugging eccentric MR jet Coanda effect, buzzwords that Sam likes to hear. Yeah, absolutely. This you can see the MR coming below the baseline because it's so eccentric. You're obviously not catching it in its full full show. And these you didn't get these values, but the planimeted and the me gradient 7, so between 5 and 10, so could be consistent with severe, exactly as you said. Yeah, I guess if they do show you an M mode, they want to hear that buzzword reduced EF slope as well. If it if you've seen that. So the planimeter 2D, which was 1.7 for this patient. Pressure half time was more than 150, it was sort of 160. Pulmonary artery pressures were elevated in that sort of severe territory as well. And then this eccentric MR. So it was a little bit tricky, like there was some that were moderate, some that were severe, but it ended up being reported as moderate to severe mixed rheumatic mitral valve disease. And this patient went to have a TOE, and then their planimetered 3D area was 1.4. I can't remember, I've been making it up actually, whether they got intervention or not. I think they ended up having a mitral valve replacement. This is a patient from another ICU. I'd have to look up my notes for that, sorry. All right, any volunteers for this second case? The patient in our ICU actually, that came 72 with a history of chronic renal failure hypertension, who came with shortness of breath and hypoxia. Maybe someone that's going to be doing the, if that's all right, someone that's going to be doing the Viva for the DDU. So that's, I think it's Michael and Rishi on today's session, isn't it? Rishi, are you all right to practice this on? Is that okay?
Of course, yeah. So on the left, we are looking at apical 4-chamber views with color or Doppler overlay. So on this window, so I can see there's obvious enlargement of the left atrium, massive enlargement of the left atrium with reduced excursion of the mitral valve leaflets. There is acceleration of color flow along the mitral valve inlet, suggestive of flow acceleration and mitral valve stenosis, and a PISA dome formation over there. On the right, I can see a 5-chamber view without any color Doppler, which shows again very minimal excursion or opening of the mitral valve, and massively enlarged left atrium. Left ventricular function appears normal in this view visually. The right side, right atrium and right ventricles do not appear enlarged. The right ventricular annular systolic motion appears normal. On the rhythm wise, this patient appears to be in sinus rhythm at this stage, despite having a massively enlarged left atrium. So now we are looking at a 2-chamber view, which is with the part of right ventricle in place, which again showing a good left ventricular function. Mitral valve shows reduced excursion, thickening of more sclerotic valves, leaflets, and a dilated left atrium. As you can see, I can see the right. I should have commented on the bowing of the left atrium on the previous images. And again, with the color Doppler over the 2-chamber view showing flow acceleration across the left mitral valve inlet, and with reduced mitral valve opening and a large and very enlarged left atrium, more consistent with mitral valve stenosis.
You can ignore that top RV focus view, Rishi.
Yeah, okay.
Yeah.
So we are looking at, on the right, we are looking at the 3-chamber views, and on the bottom right, we're looking at the focused view of the left ventricle, aorta, and the mitral valves, again showing very thickened, sclerotic or calcified mitral valve tips with very reduced excursion and a dilated left atrium. Left ventricular function appears normal. So this shows a continuous wave Doppler across the mitral valve inlet, which shows a mean gradient of around 5 and a pressure half time of 122 milliseconds, which are more consistent with moderate mitral stenosis. The PS systolic pressures are elevated which is more consistent with a moderate mitral stenosis, along with the raised right ventricular systolic pressures.
Nice, Rishi. Very nice. Again, your cadence is good. I think you speak really well when you're going through that really nice rhythm, and you know, quite clear when you're talking. So that's half of the battle with these vibers, trying to do that when you're a bit under pressure. A couple of things to point out though, Rishi. I think the key thing is to I don't think you're going to get a calcific MS. I think if they're going to show you MS, it's going to be rheumatic probably in the DTU, but hey, I stand to be corrected. You definitely might see mitral annular calcification. And I think that's the thing that I was just really wanting to hear, like clearly from the beginning, like it's mainly the annulus that's heavily calcified. So this is, I mean, it's hard to, there are ways that you can grade MAC, mitral annular calcification, mild, moderate, severe. To me, this is moderate to severe mitral annular calcification. And the leaflet tips themselves, you can't really see them that well here. Yeah, I guess the other thing on this one is just bowing across of that, suggestive of raised left atrial pressure. Yeah, you can see the leaflet tips themselves though here. They probably are a little bit thickened, I agree with you, but can you see the main crux, as we said, with that calcific MS? It's in the annulus. And you can see, you know, terrible mitral annular calcification. But I agree, across that commissural line, there is a bit of calcification as well. Just when you've got a lovely description of the color flow, I guess just trace MR. I think is it reported just trace MR, but I mean that's minor, very minor. And definitely, like, you probably wouldn't even notice if you didn't comment on that, to be honest. And the other thing, yeah, just try to, I guess maybe I'm being a bit, but when there's color on, you can't see the excursion of the leaflet so well. So you can really only comment on the color. So just try and, you know, for this, you're absolutely going to describe that anatomy in 2D. You know, you're going to do that quite concisely, as concisely as you can. And I'm not concise. I struggle with that. But this, when there's color on, yeah, it's hard to comment on what the leaflets are doing that much, because the color's taking it over. And then again, I just wanted to hear that class about mitral annular calcification, because I think you were saying calcification of the leaflet tips, and you can see the leaflet tips here, they're relatively spared. Yeah, it's a little bit pedantic. And then the mean gradient, 5.6. So yeah, between that 5 and 10. So who knows, it's elevated, right? Pressure half time, I mean, it's probably reasonable. It's probably not the best tracing. It's slightly concave, this one, but yeah, it's not above that 150 mark. And I haven't given you the mitral valve area, which would come out, but it would come out, I think, there it is, 1.8 to 2.1. So sort of in that mild to moderate category for the mitral valve area calculation there. And this is not above 50. So it's, I mean, putting it all together, knowing that it's calcific, it's not rheumatic, looking at the 2D appearances with this, you know, relatively, you know, not too severe, going through the inlet there, relative sparing of the leaflet tips themselves, RV not looking too bad, pulmonary pressures elevated, as you said, but not severely elevated. Combined with all of this, you know, it's probably more in keeping with a you know, mild to moderate stenosis, rather than severe. It's really nice. And that's just, the first one was obviously rheumatic, and again, just highlighting for you all the differences there. So that classic doming, leaflet tips, reduced EF slope, you know, all classic in your parasternal long axis and mitral and M mode. And then again, no significant mitral annular calcification, as Michael was saying, but leaflet tips severely thickened. And yeah, so the differences there between the two. And then just to finish off, a bit of a bonus case. Anyone want to do a spot diagnosis of what this could be? It's I think it was a lady in her 50s, actually. Some really nice loops there. It's a bit like spot the abnormality, what it could be. Yeah, very nice. Yeah, so this huge mass, sort of heterogeneous mass in the left atrium, taking up most of the left atrium, and protruding through into the LV. You can see it beautifully on M mode, just filling that whole mitral inflow. But they like to show things like this as well. Again, that snapshot in, you know, and say what could this be in the ASA exam. It's It's obviously connected to the intratracheal septum, as they often are, and you can see it just coming through the mitral inflow there on the short
Almost
axis.
like contrast filling the left atrium up there.
Yeah, well, yeah, other thing, I guess, thrombus, other types of tumor, would be, differentials for this mass. Again, they could show you this in the DDU and ask for differentials of this mass and what you would like to see next and all of that. So you'd want to know whether there's obstruction, right, of the mitral, whether this patient's also got functional mitral stenosis as well because of the myxoma.
Just on the short axis view of that previous image, towards the upper 1 o'clock position, there's something on the atrial mitral valve leaflet motion, which is a bit abnormal with restriction.
The anterior leaflet. Yeah. Oh, on this one, you can see it's probably getting caught a little bit by the, so if we see it on here as well. Probably it's getting a little bit caught because that's bulging up into it.
Into the left ventricle.
Into the left ventricle, and then color, you can see it nicely actually, what you were saying there, Rishi, with the, it's needing to sort of skirt around it and then come through and up. You can see that nicely in that color there. Same here. So there was some functional stenosis for this patient, all that turbulent inflow coming through. I don't know whether I've got the gradients for what it ended up being. It's amazing, isn't it, how the blood just gathers around that huge. Yeah, and the gradients ended up being about 10. So there was functional stenosis. So pedunculated adherent to the intratracheal septum. It measured this much. It was protruding into the mitral inflow, causing moderate mitral stenosis. Myxoma seems most likely. Thrombus, other primary or secondary tumours are differentials. That's how it was sort of reported. Good. All right. We'll end it there, I think. Thank you all very much for joining again. Do you have any questions? Yeah.
Thank you, Emma.
All right. You're welcome. Have a good afternoon. See you. Bye.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @Echo Nepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.